in the next few days. So if you want to rewatch, then by all means, you'll be able to do that. Please do use the chat if you have any questions, or if you want to introduce yourself, say who you are, what organisation you're from, and what you're hoping to get from today. Or by all means, do use the raise hand function if you have a question to ask as well. Without further ado, though, I will hand you over to Andi to introduce himself, and I will leave you in his capable hands. Thanks, Andi.
Thank you ever so much, Phil, and thanks again for organising this event. And hello to everybody out there. And it's wonderful to see you. My name is Andi Orlowski. I'm a health economist, but I'm also spend a lot of my time in pop health management, looking at the different ways that we can help best serve our populations and address inequalities. And I was incredibly lucky to meet Stefan Peterson, our speaker today, when we were invited over to the Karolinska Institutet to see some of his work. So not only is he a public health physician and professor of global health, he is an amazing, passionate speaker about pop health management. And I was very, very lucky to spend this time with him and go on a tour around Sweden, seeing some of the exciting work that the Karolinska and its partner, Uppsala University, were looking at. But I know he's done much, much more than that. And I won't take up any more, and I'll let Stefan introduce himself properly. But hopefully you'll find it just as exciting as I did to understand his work around population health prevention and looking at precision medicine. So over to you, Stefan.
Thanks, Andi, for having me. Great to well, not see you all, but to be with you all, as it were. And of course, I'm going to do the usual thing and share too many slides with you guys, which are going to pose many more questions than answers. And so I hope we'll be in a position actually to discuss at the end of this, and I'll try not to be too lengthy. Are you seeing my slides now by any chance?
Yeah. Yes, we are, Stefan. We can see them.
Lovely. Then it's worked out, and I'm going to save some bandwidth by showing you a picture of myself in my youth. Now, I thought we would talk about health systems, of course, as usual, but actually making a shift to systems for health and thinking about whether precision, as in precision medicine, could also be applied to prevention. In fact, one of the inspirations here, before we go to medical, is actually a quote by my boss when I worked in the Ministry of Health in Uganda. Professor Omaswa used to say, health is made at home and hospitals are for repair. So I thought I would show you my home, where my health was built by my mother, I must say, more than my father, although there's direct and indirect determinants, etc. And a beautiful picture of me in my youth, which I actually spent in a village in Sweden, which now has about 50 inhabitants, that particular village. Now, that's a bit increasingly rare in the world, because the world is now 55% urbanized, and we're going soon on 70% urbanized in the next 20 years or so, which means that a lot of my spinal cord reflexes, both sort of from my upbringing and from my professional life, are actually wrong because they refer to the rural area, which obviously is not wrong. It's a sizable proportion, as you can see here, but increasingly children will be growing up in urban areas. And we actually had the opportunity between Unicef, where I was the chief of health at the time, and WHO, Anthony Costello, if you know him now, back to UCL and the Lancet, to have a Lancet commission called The Future for the World's Children. And we systematically went through the health determinants across sectors. And we found that transport sector, leading cause of death in all continents now in young people once you pass 5. Not necessarily because you're in the car, but you're getting run over by the car, and because the city planning and the car is unsafe, etc. Agriculture and trade. I'm sure you're familiar with half of us being overweight. but also a third of the food being wasted, and the food sector being a third of the greenhouse gas emissions. So that's a sector we haven't even started transforming, like the energy sector. Urban planning obviously follows from the urbanization slide that I showed you, and I spent a lot of time in Kampala, where the city extension does not include any parks and hardly any pavement. So the question is, where are you going to get either relief from the increasing heat, and where are you going to play, and where is your soul going to reload? When I went to medical school, air pollution was bad for your lungs, but increasingly we know that air pollution is bad for just about every system in your body. And I think WHO is now up to 7 or is it 8 million deaths per year from air pollution. And the link to obesity, diabetes type 2, cardiovascular disease, I think is intriguing and scary. We also looked at, in COVID times in this commission, social services, family services. As you know, a lot of things, health may be made at home, but there are a lot of things that you don't want to happen that also happen in homes. And social services, family service are increasingly weak. And when poverty, lockdowns, or whatever strike, whether you're in the Nordic countries or in the poorer parts of the world, domestic violence goes up. The urban expansion also comes with poor housing, informal settlements, a euphemism for slums, where a lot of kids grow up, where you're not just the quality of housing is obviously one thing, but also the lack of all the water, sanitation, social services, education that come with growing up in an informal, unplanned settlement. And then finally, I wanted to spend a minute on education, because Sweden may have been one of the exceptions where primary school was not shut down during COVID, but for 1.5 out of 2 billion children in the world, school was closed down for at least 6 months. And in the case of my second home, Uganda, for 2 years. And coming back out of COVID, it's now 70% of 10-year-olds that can read and understand a simple text properly. So they may be back and going to school, but they don't seem to be learning in school. And that's not just the COVID lockdown effect. It's actually an effect of a learning crisis, the fact that schools are places you go to in many places, not necessarily places where you learn, unfortunately. All of these health determinants now, your physical, your food environment, your social environment, all these determinants lead up to problems. The Unicef State of the World's Children the other year was on adolescent mental health, and it stated 1 in 5 have a mental health problem, and 1 in 7 actually now have a diagnosis in adolescents around the world. Overweight is increasingly an issue. The Americas are still the most overweight and obese continent. And here you look at adolescents, 10 to 19, where 1 in 3 in the Americas is overweight or obese. In Europe, we're at 1 in 4. And even in Africa, this is growing. And you see some intriguing sex differences here across different continents of the world. This is actually combined with physical inactivity. We spent the last 200 years since you guys invented what's it called? Watts, the steam engine, to actually do away with physical activity, right? And now less than 1 kid in 5 are physically active at least 60 minutes per day. And in the case of Sweden, it's worse on the weekend than during the weekday. So obviously parents are also not active, nor are kids, and we're all in front of our little screens. So obesity, overweight is going up. And here are a couple of projections for where the cost of obesity is going as a percentage of GDP across some high-income countries. You see Australia on the left going from just under 2% of GDP, which is, by the way, what Sweden is struggling to pay to join NATO now. And and increasing. But look at Brazil, Mexico, Thailand, and others. They're headed for a whopping 5% of GDP as a cost of overweight and obesity. So talk about sort of the, well, on the one hand, loss of resources, but also a potential dividend if we get things right. Now, this results in unfortunate health outcomes, of course, and here's a case series from America of people dying before 70 years of age, if I remember correctly. And what was deemed to cause that death? Well, sort of healthcare as a cause of death was 10%, so we're at least not killing a whole lot of people. But look at the other factors here. The genes, which we're extremely excited about now, 30%, environment 20%, but lifestyle, and I would call it life condition, because for many of us, it's the life condition we find ourselves in that actually make the choices for us, not ourselves, right? That's a whopping 40% here. So much as the Nobel Prize medal is now given for healthcare, and this year actually for mRNA, wouldn't it be lovely if we could actually get the Nobel Prizes awarded for life condition and lifestyle interventions? Now, let's think about life. For most of us, it actually starts out pretty well. We're healthy, but then over time and over the life course, we develop various risks that will ultimately make us sick. Now, in Sweden and across Europe, how do we spend the healthcare budget across this continuum? Well, it turns out 97% care, 3% on prevention. Yet, for some average return on investment between prevention here and is 1 to 6, which is obviously highly variable, but you get 6 whatever back for one investment, pounds as it were. Yet WHO Europe says that 80% of heart disease, stroke, and type 2 diabetes is preventable or avoidable, or I would argue delayable, and a third of the cancers. Because it's not like we're going to do away with illness altogether, but wouldn't it be better to be sick later rather than today? And later it needs to be. Here is the population projection for Sweden for the next 50 years by age group. And if you understand that or is the same words as year, which is the good old Viking language, or meaning year, you'll see that it's the more than 80-year-olds that are really going to increase. So 20 years from now, which is where, that's somewhere here, when I turn 80, there'll be 70% more 80-year-olds, and we will have doubled that proportion by 2055 or something. So the old and the very old are getting relatively more in our societies, and I'm sure that's same for the UK as well. And with age, we get more and more chronic diseases. And this is also for you to practice your Swedish here. But if you're 65, if you're an individual 65 years or older, äldre, then 2/3 have multiple chronic diseases. 16% have one, and 18% are still without chronic diseases. So with age, you get sicker. Oh, well, that's not I mean, we all know that, don't we? But what does this mean? Well, here are Swedish municipalities and Swedish regions, and the municipalities take care of the care homes, and regions take care of healthcare in Sweden. And if you look at their costs, they're actually concentrated over here in childhood, putting you through school, taking care of things, and to some extent healthcare, particularly the first year of life. And then again, after 75, 80, 90 to 100, certainly the healthcare costs go up to the regions in blue, but it's actually putting you up in a nursing home, getting someone to wipe your bum, as it were, which is really costly in that older age groups. And these costs driven by demography are likely to go up 30 to 40%. But even more so, even if we find that money, we will actually need to consume the whole birth cohort in Sweden as labor and going into care for the elderly. And I'm not sure robots are going to really be replacing people there. Maybe they will to some extent. So what are now the options to handle this cost? And I would say resource escalation following from demography. Well, obviously, we can ask for productivity increases and tell our overburdened nurses to work even harder, and many more of them will resign even sooner. We can, and I think we've already started in some places. Stockholm just raised the taxes by, well, 0.3 krona, which is a very, very small amount. That's about, what, 3 pennies or something like that. But nevertheless, tax increases, we can and we are increasing retirement age, people contributing longer, paying taxes longer, etc. But obviously for you and this audience, the message is to delay the onset of illness through health promotion and prevention. So doing that, what are the options? Well, obviously, we're told all the time to make the right choices in health promotion and primary prevention. But I would like to argue that I make very few choices myself. It's work. You need to be in an enabled environment. And that means the built environment, the architecture, is there a staircase to be found in the city planning? Is there a pavement? Is there a park? The food environment, what I generally eat what gets put in front of me and what's advertised. Can we change that to make my choices or easier, as it were? And the social environment. I also hang out on the new form of social environment, which is online. And when you're on Twitter, I guess you realize that it's not a very healthy social environment. Usually I get, whenever I express some opinion there on public health, I get told off by some anonymous bots that I have zero intelligence, etc. So that's probably why they renamed the thing to X. Where are these environments, though? Well, obviously, Twitter and X, that's sort of in some cyberspace, but the food environment and the built environment is not at national level, it's at municipality and city level. And that's where I think we need to concentrate a lot of these efforts. Now, giving you an example, though, how nudging can be done, the right-hand side here, one of my high school friends ended up moving from Sweden to Cape Town, and for lack of a national health service, he has to buy his own health insurance from Discovery, an insurance company. And they have a program called Vitality, which nudges him all the time to eat his lunch in the gym, rather. Well, actually, the story was I visited him. He said, can we have lunch at my gym? And I said, why? Do they have good food? And he said, no, I get the lower premium if I check into the gym. And if he takes his kids to the dentist, he gets free movie tickets. And now that his son is learning to drive, he's so proud that even the son is not triggering the reckless driving sensor that the insurance company has put in his car. And Swedish healthcare, we also have some element of primary, secondary prevention. When you're 60, when you're 70, in some regions, you're called into so-called directed health conversations with a nurse or with a doctor, whereby they've assessed, you see on the right, some of your situation, and then you have the traffic lights, and then you talk through your situation, what you need to do, and there's actually very good evidence from some of our regions that this can actually be quite effective in delaying the onset of illness and disease. Secondary prevention is, of course, when you're already half sick and you need to find it and it may prevent it from getting worse. Diabetes type 2 is sort of, as you know, the world's soon most common disease. Soon there will be keep forgetting. Is it 2 or 3 billion with diabetes type 2? I mean, it's sort of staggering what's happening. In Sweden, it's 5% of the population. In Uganda, it's now 10%. And in parts of India, it's 20%. So really, it's a very dynamic type of condition. So question is, we can, of course, screen through various social media and others, which this company called Health Integrated does in Sweden. They send you the FINRISK questionnaire. You answer a couple of simple questions. Based on that, you might get called to a long-acting blood sugar test. And then, if you're found to have pre-diabetes, you're offered £500 on a virtual account and a coach to keep you busy and on it, to change your life. And if within 3 years of life you convert to diabetes, then the bond market, where the region borrowed the money for this, is losing. And if you're not converting and you go back and you become healthy, then the region is paying back to the bond market. So all of this on borrowed money, as it were, which really increases addresses one of the problems, the 97-3 gap in financing, right? And convincing healthcare to let go of money for prevention. Now, we're social animals, though. And typically we tend to address individuals and saying, you make sure and you fix and you, etc. But if you address us as a group, you do much better. The MAGIC trial in Bangladesh also looked at pre-diabetes and compared one arm sending SMS messages on what to do and the other one where they actually had study groups around diabetes. How do you eat different? How do you walk different? And whatever they did. And the adjusted odds ratio was 0.39 after 2 years, the cumulative incidence for conversion. To me, that actually says that we ought to have area-based responsibility with some type of community health worker who can pull along some of us into whatever it is, reformulating your cooking class, walking with funny sticks early in the morning, as people tend to do in Sweden, or whatever works for you. To me, this begs the concept now saying, can we move from precision medicine to a concept of precision health? And we actually worked out a definition in the Swedish language, which you'll see down to the right. And then I've attempted to translate it to English. Precision health aims to improve and more equitable health by using data on individuals' biology, their lifestyle, and the socioeconomic context to prevent, diagnose, and treat with precision. So it has the vision and the aim of improving health, making it more equitable by using data. And there are 3 levels of data. One is on the biology and the omics with all this enthusiasm. Second one is on the individual lifestyle. Why don't we tap my phone? Why don't we tap my grocery card for data? And my socioeconomic context, my education level, that whether I'm single, with a family. And as you know, the postcode is an important determinant of health. How can we actually integrate that data and do something meaningful with it to prevent, to diagnose earlier, and to treat better with some element of precision? And then as we start summing up here, I'd like to give away, I think, one of the big areas, I think, where we need to move, and that's the food systems transformation, where we need to decarbonize, not just from oil, but also from the foods we eat. Hyper-processed is sort of, it might be a catchy name, it's sort of hard to use as or ultra-processed, etc., as many will tell you, but you know the stuff I mean. It's all sugar, it's all carbohydrates, it's all hyper-processed, this and that, and it's not good for you. We can address it through various restrictions and legislations. I'm sure you are all familiar with the problems and fallbacks of that, but also, as I made this slide to talk to the European health insurance industry, I told them, not only may you want to nudge your clients on health or life insurance, but why don't you talk to your back office of divesting from actually these companies who produce this nasty stuff that actually makes us sick. So that's why my plea is actually to say that while health systems are nice, it's actually systems for health we need, where most of the attention is in other sectors than the healthcare sector. Thus, health is made at home, or it takes a village, or as you know. Unless you've read this report, I can recommend it, the flagship report of the Alliance for Health Policy and Systems Research. You can download it freely from the web, Systems for Health. Everyone has a role. And that's where I wanted to stop the showing of too many slides and seeing if we can have some live interaction and make a social environment here, which might even be conducive to health, Andy. What do you think? Or do you throw things at each other here?
Thank you ever so much, Stefan. That was absolutely wonderful. And again, for the people watching, please feel free to either raise your hands, or you can always write your questions in the chat. But as always, I have some questions first, Stefan. In England, we have these integrated care systems, this idea of how we can bring together not just healthcare, but look at bringing in a perfect world, environment, education, justice, and our local authorities, public health and beyond to work together. But we also know that system working is very difficult to do, and that many people have different agendas, different ways of measuring success. Have you seen anywhere in all of your work where people have cracked system working to be able to deal with these wider determinants, to be able to do some of the work that you've talked about?
I'm on the lookout. Can we say that? If you look at the high income setting, I would say that Victoria Health, Vic Health, has a very exciting strategy now, which actually deals with young people and a multi-sectoral approach to things. Vic Health, and I'm sure you can Google it and toss it around. That's sort of not proven, but to me, that's a very exciting type of document. I also heard that last week at the World Health Summit in Berlin, that in parts of Germany, they also have something similar to what you described. I think area-based, trying to integrate services, which is something we're sorely lacking in Sweden. We have sort of inspired by whoever we have. You're listed with a GP across town, whom you might see once in a blue moon. And what's that going to do to your health? Absolutely nothing, I think, at least at the prevention stage. Then if we go to low and middle income countries, I think it's the celebrated community health worker, sort of, that we're all dreaming about. We're not paying them anywhere, but there are many examples, smaller or larger cottage or up to medium size programs where you actually support community health workers and they're able to do wonderful things. So far, I think that's been mostly in maternal, newborn and infectious diseases. But I think also inspired by that Lancet piece from the MAGIC trial from Bangladesh. That's some element of community mobilizer, whatever, bringing us together who have a bit too many risk factors and doing something about it. So that was a long-winded answer to say, no, I haven't seen it, but I think there are bits and pieces here and there across the world. And when we did pre-diabetes EU study across rural Uganda, townships in Cape Town, South Africa, and immigrant-dense suburbs in Stockholm, it was actually the Ugandan low-income and South African middle-income healthcare system that were better equipped to deal with these issues than the high-income Swedish one. Over.
So, Stefan, we've started to look at this in more detail, and the brilliant Jack Ettinger and Sophie Hodges have done some work using multi-criteria decision analysis. We know it's been around for years, but this idea of getting systems to agree on what's important to be able to then hopefully make decisions based around some shared, some shared values. So hopefully we can find an excuse to come over to see you at Karolinska to share some of that work around multi-criteria.
That would be lovely. And in fact, I can give it away. I'm now based at Makerere University in Kampala, so maybe you'll come here.
Oh, well, fantastic. Yes,
I negotiated a sabbatical.
Oh well, they've had I was in Warsaw just the other week, so well, let's catch up. But one of the other bits that just want to talk about was the talk of digital, and that and again, when we were together in Sweden, we saw some of those GP practices that use digital hubs, because how do you encourage GPs to come to these rural settings? You get those guys who are really interested in a certain topic, let's say if it's research or if it's, in this case, digital technology, and you had the population coming and getting the bloods taken remotely, the blood pressure taken remotely, all of this kind of wonderful stuff. But you also talked about how people game the system with digital. So have you seen somewhere where digital has worked well in precision, I can't say the word, in precision medicine for prevention? That I kind of is, again, where's working well, what's working well?
You found me sort of on a learning curve here, Andy. So you're asking all these difficult questions. Maybe you'll help me find this, and then I'm sure the people here. But you know, I can tell you one thing though, is that much as sort of there's some impressive results from some of those remote practices in Sweden that you referred to. At least I think we're just starting the digital. We've just written a concept note on precision health for the European Union, and harnessing the increasing amounts of data. There's actually no examples of that really working out. Combining different types of data, yes, I mean, we're typically quite good at the blood tests or whatever, right? And my physician never asks me any questions about how I lead my life. I don't know about you. My physician never asks me what's in my phone and what's on my grocery card. And yes, he does know which part of town I live in, but no social anamnesis, whatever. And that seems to be across the board in various systematic reviews, that we don't use artificial intelligence or anything to integrate this sea of data that we could potentially be swimming in. We also don't use it to predict what is a better intervention for you, Andy, given who you are and what are your issues, what's your heritage and what's your postcode, etc. Because I mean, suggesting to a single mom of 3 that she should start going to the gym, I mean, that's sort of anyhow pretty hopeless, isn't it? I don't know about suggesting it to you, Andy. So I think there's a ton of stuff to be done there that also needs to go beyond the classic healthcare data. And I think in the case of the overburdened GP, I mean, first of all, most people for promotion and primary prevention are not even known by the GP, right? But once you are, given all the protocols in the Swedish healthcare system, a colleague made a time needed to treat analysis. And it turns out if the GP was going to do all the things required of her or him, he only needed to work 27 hours per day.
But I think you've hit the nail on the head. Well, we often call it impactability, this idea that there's a whole raft of interventions that we offer, often straight from the shelf, that aren't in any way particularly tailored for the individual. So yes, you're at risk of a heart attack, Andy. Yes, you should go to the gym or whatever the appropriate thing is, take the right drugs, go on the walking classes. But again, it's inaccessible to me because of my job or my lifestyle. And it's that kind of better understanding of individuals. And we're starting to do a bit more of that kind of work now. But there's always a tension, I find, because, of course, off-the-shelf solutions tend to be relatively economic and, and high value, or certainly have an efficiency because of the numbers bought. But, of course, not high value if no one can engage with them. And so in cost-constrained systems, you tend to go for the easy solution. I'm hoping that you hit 80% of the population, leaving 20% behind, often people with poor access, maybe poorer outcomes, because they have this trade-off analysis that doesn't involve the individual.
Yeah, and then we're back to Jeffrey Rose's sort of, what's it called, prevention paradox, and how much of the risk is concentrated in a definable subpopulation and blah, blah.
Yeah, and I think it's right, and then it comes back to again a really important point that you made about community being involved in health and healthcare and choosing solutions that they want. And I think that's so important about I say different cultures, different populations want care delivered in a different way, and they may be living right next door to each other or a street away, but how they want to consume healthcare is different. So when you've seen those examples of communities working together on solutions, what's your best example of how that's made a big change in prevention or in or for people's health?
Well, to me, I used to study this with community health workers and intervention around maternal newborn health and going to antenatal care and place of delivery, etc. And I think there's a couple of impressive examples around the world where I think we're typically sort of NGO-supported community health worker systems have been able to turn things around. But I would love to be corrected, but I have yet to see a government system that takes this to scale with the nimbleness and the kind of support that is required to keep that engagement. Also, I mean, in Uganda, if you look at Bangladesh, because when I was sort of, pardon me if someone's from Bangladesh on the call, but when I was a kid, Bangladesh was sort of written off as a lost case somehow. And then through extreme community engagement and community-based organizations, BRAC, for instance, Bangladeshi Rural Advancement Council, not only did they go door to door and teach everyone how to mix the sugar salt solution, bring diarrhea mortality, they brought in, as you know, Grameen Bank, microcredits, all of those things, and really turned the country around. So interestingly enough, BRAC, one of the sort of state-carrying NGOs, as it were, almost in Bangladesh, is now in East Africa. So I'm still very keen to see how will that translate. Will you have that community engagement here, or will it become another NGO, as it were, when it leaves its home? So I think, to me, that also implies that probably these solutions are probably contextual. You can borrow some principles, but then in your social compact and your system, you need to bring it down. But for us as sort of healthcare professionals, I think we're also constrained by ourselves and our own thinking, because the community health workers who help the mothers get to deliver in hospital, etc., that I referred to and we set up and evaluated, blah, blah. And then they were so proud, and they say, and our next project is going to be to buy a maize mill. And then said the women, and then, I thought, but this is a health project. But then I realized, well, what better use of saving women's time than buying a maize mill, isn't it?
And again, it's these wonderful, exciting things that the community can come up with that have, very practical, and again, if it's helping the socioeconomics as well as personal behaviors, again, can have things that we just couldn't possibly think of or wouldn't think of as part of our daily routine. I have one last question about long-term care in a second. So just to warn everybody else who's listening, if they would like to get their questions in. But Stefan, we're spending a lot of time with my work with the World Bank looking at this idea of long-term care. How do we care for the elderly population across, and in my particular bit, Central and Eastern Europe, there's a huge proportion of the care given is through informal care. And as you mentioned, there's this big gap as we have babies later on, and the costs associated, because we're so good at keeping people alive now, that there's a huge cost associated with that. So again, your experiences on, and your thoughts on what can we do? What are the practical things that can be done by us today or in the near future to help close this big gap that will be growing very, very quickly as we try to support those with disability and those with long-term care needs for our populations?
Well, one is to do all of those things that we know we should be doing and we're not doing, and actually stop blaming the individual for that. I mean, and actually enabling the determinants of health to work for you and with you and make the right choices, the easiest choices, or at least easy choices. And I think we have a long way to go there. And then I'd be delighted to hear about what you're doing if you can get sectors and others to agree on that thing. And that's sort of to delay the onset. Then the other element, I think it's also as we look at the population dynamics in the world, because of course, you can try to sort of whip the nurses to work even harder, but I'm not sure that's going to work, right? So we're also going to have to accept migration, I think, because however good robots you make, I'm not sure that they'll be able to, or I even want them to wipe my bum. And who's going to be doing that? I have 4 kids, none of whom aspire to either stay at home and do it. Informal care is often done by women, isn't it, as well? Nor do my kids aspire to go to work in a nursing home professionally. Yet, when you're in the airport here in Uganda, where I stay now, there are all these young women by the hundreds being sent to the Gulf to work as maids with all the social risk and for negligible income. Why aren't they trained to become nurses? Why doesn't one of the other regions in the NHS actually set up a deal with a private nursing school here in Uganda, send a nurse tutor and saying, whoever meets these criteria has a guaranteed job in the health service. So I think we're going to have to come to terms with migration across the world, because 4 out of 5 continents now have aging populations, and it's only Africa that has the labor reserve to step into that. So a combination about prevention, I think, and enabling the systems transformation, and which is, I think, comes back to the people on this call, but also trying to sort of figure out how we can teach Europeans and other xenophobic places to get out of our populist corner now and accept the Polish plumber and the African nurse.
No, and I'm with you. And I know that the wonderful Alejandro is on the call with us now from our work together at the World Bank. But funnily enough, in Poland, when we were speaking to experts about how they saw the profession growing and changing over time, even though in COVID, they used digital solutions to be able to see more patients and to do and to be able to interact differently and to be able to do those pieces. When we asked them what do they see for 2050 in the next 25 years, they just said more doctors, more nurses, more healthcare assistants. There was no, oh, we should go back and start doing more digital solutions. And as you say, the idea of putting up taxes and getting migrant workforces are not particularly attractive. And funnily enough, Poland is only natural resource is its people, and yet they too have this kind of big gap kind of going through. So I think it's going to be a really interesting challenge on how people can engage to be able to.
But can I tell you, I did an unethical study once, not reviewed by an ethical committee. I had a chance to attend the G20 health ministers meeting. The 20 health ministers from the 20 richest countries in the world, and I sat there, and then as I listened to all the health ministers, all 20, I characterized them as a health or a healthcare minister. And it turned out in the end that 19 out of 20 were ministers of healthcare, talking about beds and nurses and tests, and 1 was a health minister. And actually, to my huge surprise, and actually, I guess my prejudice is the health minister was from Saudi Arabia, because he was talking about public health interventions. But I guess it's also a question about the doctor dominance here, because medical school closes your mind to many things.
Yeah. Well, it's funny, and you talked about the attractiveness of the roles, and there's no one wants to go into long-term care, nursing, long-term care as a whole. As a profession, it's seen as right down the bottom of nursing, and not particularly glamorous. You're dealing with, again, I know these are, horrendous stereotypes, but cantankerous old people who are very set in their ways and may not be as willing to receive the care in the way that you want to deliver it.
That's seen one as a very tough job. But the other element is also that it's hard physical labor, because if you go to work in industry now, there are all these machines. But I mean, I worked in nursing care, getting someone to the toilet and back and doing that. I mean, that's hard labor. My back was aching.
Yeah. And it's how we engage with other communities and and push digital going forward. So guys, I've rabbited on with Stefan for absolutely ages. Are there any questions from the audience, from those in the meeting, besides me having a gossip with my friend? Phil, you've suddenly appeared as if you're going to ask something really exciting.
Like a really bad MC, just appeared out of the ether to see if anybody has any questions or if they want to put them in the chat and we can read them out if they'd rather not ask out loud. It seems like you rather comprehensively covered all of the topics I think people were interested in. Oh, that's a good one from Laura, though. Should informal carers be paid?
I'll let you go first, Stefan. I have views on this.
Well, I was going to say, if you're not married to them, or whatever. I mean, this is the mother of all gender issues. We're sending women back for unpaid labor at home, isn't it? Sweden does have a policy, actually, where people who satisfy various criteria have a right to assistance in the home, and can actually, and it has empowered and enabled a lot of people, typically in younger ages with various types of disability, to lead more active lives. Coupled with deinstitutionalization, I would argue, though, and this is only personally my view, that a lot of them are now isolated in an apartment with 3 carers doing sort of 24-hour shifts. So I'm not sure. I mean, if you had a moderator on what a boutique-sized institution, maybe even me with the need would meet someone else, and the carers would meet other people. So I think, yes, they should be paid, but I think they need to be paid with some kind of consideration and risk awareness as well.
Yeah, and I'd say there should definitely be, so we've been talking about different ways of how we can pay them. So are there kind of wonderful tax benefits that you can provide to make sure that it's cost effective for people to be able to do things at home? But as you say, Stefan, and I think as Laura's alluding to, often, certainly in Central and Eastern Europe, it's seen as the eldest daughter's role. And so the eldest daughter is expected to effectively give up her job and then care for her parents. And if that were to happen to me and my partner, so we were 40 when we had our first kids, so that means that my daughter would have to give up her job at 30 to be able to care for us. And I don't think my daughter, as again, aspires to have to look after her dad and wash and clean me at the age of 30 because of this big gap. So how do we make informal care for those who want to provide it? So it doesn't have, is it not your family? Are there other people in society who would be willing to provide care? Then it becomes more formalized. Or if it's neighbours and friends going from there with tax benefits or pay. But as you say, Laura, it's certainly a lot cheaper to pay for this informal care. But wouldn't it be nice if there was a kind of a minimum standard that informal carers had to go through a few hours of training on how best to take me to the toilet, how best to wash me, to make sure that they don't drop me. So we pay them.
Or protect their own back so they don't break their back doing it.
Exactly, so they don't end up with musculoskeletal pain. So I'm fully behind paying people, but I think that there should be some kind of structure to make sure that they're providing the best possible care, you know, and therefore we pay them as related to that. So absolutely, and it can only be cost saving, I feel, in the long run. And again, how we adapt people's homes, making sure that we have things like, you know, grab rails, easy access toilets, making sure that houses in the future are built so they can be adaptable. In Poland, there's this idea that you're trapped on the 4th floor. So there's a whole load of people. So in the 4th, you don't have to build lifts in flats over 4 floors. And so there's loads of accommodation that's built, and sadly, elderly population live there on the 3rd and 4th floor, struggle to get up and down on the stairs. There will be no provision for lifts in the future, and therefore they get lonely, they don't get out as often, and therefore, sadly, they pass away earlier than they should because of it. How can we get that informal care so someone's running up and down the stairs for them, or we're making sure that these houses are more adaptable in the future? But yes, we support you, Laura. Let's go out and get that money.
But you know, Andy, on the lift, though, you and I shouldn't be riding the lift. It should be there But I'm sort of also, I mean, it's a challenge to people like us to figure out what's the nudging there. For me, I found if you have an electric opener in a time delay, you need to press the button for 10 seconds. Then I'm too impatient. Then I walk up the stairs. So that works for me. But it would still give people in a wheelchair an ability to ride the lift.
Yeah. Yeah, there's Muir Gray writes this wonderful work about the fact that older you get, the more exercise you have to do. But the exercise you do starts to change. So a colleague of Stefan's, Alejandro's and mine, Anna Cogel, she's now, rather than doing lots of aerobic, she's now doing weightlifting and starting to do some other stuff to build muscle mass to protect her as she comes into older age. Because again, you definitely need to do exercise. If you can walk the stairs, definitely walk the stairs. But it's a balance for those who maybe the super frail at 85, don't have family to look after them, can't get downstairs, don't have someone to help support them. How can we go from there?
I've got a question here as well from Tyrenum. Sorry if I've pronounced that wrong. How can it be made attractive, excuse me, for a non-clinical NHS role to move into a clinical role to increase the workforce? And how can retraining be made available and affordable for those wanting to change career whilst having to work? Can apprenticeships be an option?
I see. Andy, that's a UK question.
Well, as I say, I think, as I think we've both mentioned, at the moment, certainly caring and long-term care isn't a particularly attractive role. It's incredibly hard work. How do we make it more attractive? One of the options we're looking at is financially we make it on a par, or we pay to make it more attractive to people. Really key. So that's one part of being able to do it. If you're a surgical nurse or doing some other bits, you get involved in other parts of the hospital. Can we do more research? Can you make it more attractive for people because they're doing elements around that? So it's not going to be easy to drag people across, but I think that there will be time pressures and money pressures that it will be cheaper to pay them more than it will be to live with the consequences going from there. And absolutely, why not apprenticeships? But again, how do you make it attractive? Saying, do you want to go on an apprenticeship and you can be a nurse in a surgery, potentially doing some really exciting stuff, work with GPs and prescribe and look after patients, be a midwife and do some amazing things about bringing babies into the world? What an amazing, career. Or do you want to look after some old people and do it this way? It's how we make that caring for the elderly, caring for those with long-term conditions and disability seen as something that has the same social worth or more as some of those other exciting jobs out there. But if we can crack that, and again, we may just have to leverage money, other things to make it exciting to go forwards.
I'm just conscious of time, but I think one last question from Harsha is, what are your views on leveraging complementary and alternative medicine for preventative healthcare?
Well, I'll quote Chairman Mao, I don't care if the cat is white, black or white, as long as it eats mice. But I think the thing is eating mice, and then the evidence, is it sort of evaluatable or not?
Yeah, and I think that's the Stefan said in the head. If there's evidence to support it, great. There's a whole load of community stuff that we did. Again, Jack and Sophie led this wonderful review when we're looking at COPD, and there was things like traditional Chinese exercise and yodeling and other things. And of course, there's an evidence base. You're doing exercise, you're doing things differently. It gives you a chance in this example to reduce COPD exacerbations, because I'm guessing you're with singing and beyond. So there was an evidence base to support these. I think most people call them complementary alternative medicine pieces. And if your community supports traditional Chinese exercise or yodeling, let's go for it. And if that's what the community wants and there's an evidence base, if the evidence base isn't there, it becomes harder to justify. But again, it doesn't mean that you can't try these things evaluate them as you go to be able to see what the outcomes are. Beetroot juice came out really high on COPD. If people want to eat beetroot juice, and if it's community, being a Pole, I eat a lot of beetroot soup. Does that mean that my COPD would be better? But let's do an evaluation as we go, and we can build learning health systems to allow communities to be able to try these things. And if they don't work, fine. We've tried them. But as I say, I think that absolutely there's there is a place for all of this if the evidence can support it.
Fantastic. Again, just because of time, I think if we leave it there, I'd just like to say a massive thank you to everybody for attending today, and to Stefan for agreeing to join us and do his wonderful presentation. It's very interesting. And for Andi, mainly for not mentioning a certain fungal problem or boilers.
You've got to say it now. That's
Stefan
thinks I've got some other horrible infection. But Stefan, thank you ever so much. As always, it's wonderful to hear of your presentations and to get your views. You have a world and a wealth of knowledge that it's great to be able to tap into. So a huge thank you and congratulations on your latest secondment. Fingers crossed we can come out and see you soon. But all the very best, and thank you, Phil.
But thanks, Andi and Phil, and all for being here and having me. But as you heard, there were more questions than answers. So let's answer questions together. That's my plea. And stay in touch. Thank you.
Would love to. Thank you ever so much. And thank you, everyone, for joining.
Bye.